In this section, we are going to see one of the important topics, and that is the Neuro Ophthal. Now, as you know, Neuro Ophthal begins with the optic nerve. So, let's see about the optic nerve first. So, this optic nerve is the continuation of nerve fiber layer of the retina. Now, all these are the presumptive MCQs, and you know, it is actually this nerve fiber layer of the retina. It actually contains the axons of the ganglionic cells. Axons of the ganglionic cells. This is another important point. It contains the axons of the ganglionic cells. And which order neurons are these ganglionic cells? So, for this we have to see what are our visual sensations. The visual sensations, because you know there is an update about this, so this becomes an important thing. We know now the first order neurons. The first order neurons are now the rods and cones, that is the photoreceptors, and this question was also asked in AIIMS May 2019. Then we have the second order. Second order neurons are the bipolar cells. Bipolar cells. Third order neurons are the ganglionic cells. So, basically the ganglionic cells which are present in the optic nerve are the third order neurons, and finally we have the fourth order neurons which are present in the lateral geniculate body. So, now we know that these ganglionic cells are actually the third order neurons, right? Another important thing is what is the length of the optic nerve. So, if you go about the total length is about 47 to 50 mm, and it consists of the 4 parts. Now, let us see what are the 4 parts of the optic nerve. If you see, this is your eyeball. Is it visible? Yes. This is the eyeball, and from this backside area, this is the optic nerve which is coming out, right. So, the first part that you can see here, this is your first part which is the optic nerve head, and this will be called as the intraocular part. Optic nerve head or the intraocular part, and this is actually 1 mm, which is the shortest part of the optic nerve, another important MCQ. Then coming to the second. Now, second is this part which is lying inside the orbital cavity. This is your second part called as intraorbital. So, I can say intraorbital, or I can say this is your extraocular. Intraorbital, or it is extraocular, and this part is 30 mm, which comes to about the longest part of the optic nerve. So, this is the another important thing. Now, if you see the third part is the part which is lying inside a canal. So, which canal it is lying inside? It is the optic canal. Optic nerve lies in the optic canal, right, along with the ophthalmic artery. And then finally we have got the fourth one. Fourth is the one which is lying in the brain, and it is above the cavernous sinus. This is lying above the cavernous sinus. Now, what are the lengths of these parts, right? It is actually 6 to 9 mm, and this part is your 10 mm. So an important thing is that the optic nerve is not passing through the cavernous sinus, and that is why when we read about the superior orbital fissure syndrome, we read about the keratoconus fistulas, cavernous sinus thrombosis, the visual acuity is not affected in the early cases. I think this is a very, very important point, because so many questions comes and all of them are giving you same sign and symptoms. So what is the main thing that you have to look, that whether the visual acuity is affected to a drastic level in the initial phases or not. All right. Then coming to the second important point, the fields. So you should always remember that the temporal retina sees the nasal visual field and the nasal retina. The nasal retina sees the temporal visual field, because without understanding this concept, understanding the visual field defects will become really, really difficult, and we can't afford that. You should have a sound knowledge of all the visual field defects, and I know that it's not a good idea to cram them up. So see this. If you see this, this is your optic nerve head, the optic disc, which is lying nasally. So this is your nasal retina, right? And the fovea, which is lying slight temporally. So this is our temporal retina. So if you see, the visual fields are always diagonally opposite. They are always diagonally opposite. So if you see, this temporal retina will make the image in the nasal visual field, while if you see the other one, see this one, this temporal visual field is formed by the nasal retina. So I think this should be very, very clear in your mind, and on the basis of this we are going to see some of the important facts in the visual pathway. The visual pathway. Now let us try to dissect this visual pathway. If you see here, what is the starting point? Whenever you are visualizing anything, basically we are starting with the retina. So that becomes the first point, right? The retina. And can you see, we have got two parts here. So one is your nasal retina. This will be the nasal retina here, and then on the other side we have the temporal retina. So these are the temporal retina, right? And we already know that the temporal retinas will look into the nasal visual field. So this will be responsible for the nasal visual field, and this will be responsible for the nasal visual field, like this, right? It is responsible for like this, and this is responsible for this. So these are the nasal visual fields. On the other hand, if you look at the nasal retina, they are responsible for the temporal visual field. So temporal visual field and temporal visual field, well, these are the nasal visual field and the nasal visual field. Right. Now, whenever you visualize anything, it is going to the first order neurons, rods and cones, the photoreceptors. That is the site of the potential generation. We have already seen in the phototransduction. Then it is going to the bipolar cells, and then it is going to what? Ganglionic cells. Where they are present? Ganglionic cells are present in the optic nerve. So our second site will be the optic nerve. So if I number them, the first will be the retina, second is the optic nerve, right? Then where it is going? Then it is going into the chiasma. So that becomes the third point. Now what is actually the chiasma? Chiasma is the decussation of the nasal fibers. Decussation of the nasal fibers is the optic chiasma. So whenever the defect is lying at the level of optic chiasma, it is lying in the nasal retina of both the sides. While if you see, what about the temporal fibers? They are going through the lateral chiasma. So if you see here, we have got this, and then we have got this. What is this? This is your number 4 bilateral lateral chiasma. Bilateral, lateral chiasma. This and this will be your number 4. So I'll highlight this also. Then after this, now next they are going to the optic tract. So this will become your number 5. Optic tract. Optic tract contains the ipsilateral temporal fibers. Each optic tract will contain the temporal fibers of the same site, while contralateral nasal fibers of the opposite side. From the optic tract, it is going to the lateral geniculate body. So this becomes your number 6, the lateral geniculate body. Lateral geniculate body is again important because you know it consists of the 6 layers. It consists of the 6 layers, 1, 2, 6. Now many a times we get a question on these layers and the pathways which are formed by the lateral geniculate body. So let us try to see this. What happens here? In the lateral geniculate body, we have got the layers 1, 4 and 6, right? They actually innervate the contralateral hemiretina, while the layers 2, 3 and 5, they innervate the ipsilateral hemiretina, right? This is one important thing, ipsilateral hemiretina. Okay, then another important thing is the pathways. It is forming actually 2 pathways. One is your magnocellular pathway and another is your parvocellular pathway. Magnocellular contains the layers 1 and 2, parvocellular layers 3 to 6. Okay, so what are the functions? Magnocellular is involved in the movement, depth and the flickering, while parvocellular is involved in the finer details. This is involved in the finer details. For example, it can be the color, it can be the texture, contrast and the other thing. Alright, so these 2 things are very important about the lateral geniculate body, and most of the times there are questions related to this. Alright, so after the lateral geniculate body, we come to the optic radiations. Next is your optic radiations. Optic radiations are the sensory fibers and they are passing through 2 lobes. We have got the temporal lobe and then we have the parietal lobe. Temporal lobe and the parietal lobe. Through the temporal lobe are passing inferior fibers, and through the parietal lobe we have got superior fibers. So different fibers are passing and therefore different areas of the visual fields will be affected. And after the optic radiations, finally it will be going to the visual cortex. Can you see here? This is your visual cortex. So next will be this visual cortex. So this will be your site number 8. So we have learned this, that actually how the visual pathway is going to follow the things, and the visual cortex lies in the occipital lobe. Occipital lobe, which is the Brodmann areas. The Brodmann areas 17, 18 and 19, right? So next is your this occipital lobe. Side by side, you should also know what is the blood supply. So the blood supply of the occipital lobe is the posterior cerebral artery, while if you see the tip of the visual cortex, the tip of the cortex is supplied by posterior cerebral artery plus the middle cerebral artery. Now this is again important because this gives you the double blood supply. That means the macular area, which is actually represented by the tip of the visual cortex, is having the double blood supply. So on the basis of this, we will be learning the most important thing of the Neuro Ophthal, and that is your visual field defects. So these are the visual field defects, okay. So we'll try to see. Now let's see the first one. The first is at the level of the optic nerve. So see here, when the defect is lying at the level of the optic nerve, now always see which eye is right eye and which eye is the left eye. Okay, you can take the other way around also, in whichever side you are comfortable, but I take it this way because you know, when you look at the patient, you are sitting face to face, so patient's right eye will not lie on your right side, that's why. So that is the logic actually behind it. So if you see now, whenever the defect is at the level of the optic nerve, same side both the nasal retina as well as temporal retina will go. So on the same side I will have actually the total blindness and I will have the normal vision on the other side. So this is your optic nerve defect. While if you see the second part, so second part I'll take later because this I have to explain you. This is actually the proximal part of the optic nerve at the junction of the optic chiasma. So this I'll take separately. Then if you come to the third thing is the central chiasma. Central chiasma is this one. Central chiasma, can you see the red fibers? So red fibers are representing what? Red fibers are actually the nasal retina. So when the nasal retina is affected on both the sides, what you are going to get actually is the temporal blindness on both the sides. So this will be called as the bitemporal. So this will be called as the bitemporal hemianopia, right? While in the cases of optic nerve, I was getting the total blindness on the side of the lesion. There I was getting the total blindness on the side of the lesion and with the normal vision, on the other side. Here I am getting the bitemporal hemianopia. Alright, now there is one more important thing that you have to see in cases of the bitemporal hemianopia. See what is happening, the structures which are lying near the sella turcica, which contains the pituitary gland, and that can cause the compression of this optic chiasma. So you have got two things. One is your pituitary tumors which can affect it, and second is your craniopharyngioma. Craniopharyngioma is a tumor which is lying in the remnants of the Rathke's pouch. Remnants of the Rathke's pouch, while the pituitary tumors are coming from the pituitary gland. Now always remember the C is for crown. So crown is always lying upwards. See for crown, crown is lying upward. So it is upward, it is above the what you call as this optic chiasma. So this is compressing the superior fibers. So this is compressing the superior fibers, and because it is compressing the superior fibers, what it will affect? Therefore, it will cause a problem in the inferior quadrant, because you know the visual field defect is always diagonally opposite. Similarly, the pituitary tumors which are compressing it from below. So how will you remember that P is for the pedal, and pedal are always distally. Pedal means the foot. Okay, so they are always downward, so they are compressing it from the below region, and that is why the defects which are occurring are always in the upper field. So can you see here, if you look here, when we have got a defect, I can even divide it into two parts, like this and like this. Okay, so this superior one will be affected in cases of the pituitary glands. So I will write here P, and this inferior one is affected in the cases of the craniopharyngioma, so I will write C and C. And obviously, if both the fibers are affected, I'll get total bitemporal hemianopia. That is not a problem. Then look at the next one, the fourth. The fourth is a lateral chiasma. Lateral chiasma means this fourth. So I have got bilateral temporal lateral chiasma affected. So bilateral temporal fibers. Temporal fibers means which field? The nasal field. So can you see here? Bilateral nasal field gone. So this will be called as simply binasal hemianopia. This is called as the binasal hemianopia. Then look at the next one. The fifth is your optic tract. So if I have a problem with this optic tract, what will happen? Now can you follow this? It is containing the green fibers of the same side. Can you see this? It is containing this green fibers of the same side and it is containing this red fibers of the opposite side. That means ipsilateral temporal. So ipsilateral nasal field will be going. So see here, ipsilateral nasal field will be going and opposite side nasal fibers, opposite side temporal field will be gone. So the first time now, what I am going to get? For the first time, I am getting called as the contralateral homonymous. Contralateral homonymous hemianopia, and you have to remember that this contralateral homonymous hemianopia is the most common visual field defect, very important. And another thing that you have to remember is that this is actually incongruous type. It is incongruous type. This is again a important thing. Now next you come to the lateral geniculate body. If you see the lateral geniculate body, can you see it has the same representation as that of the optic tract. So I am going to get the same thing in this lateral geniculate body also, that is your contralateral homonymous hemianopia. That is not a problem. Contralateral homonymous hemianopia. But if you see the next one, that is your optic radiations. So optic radiations, we have got two parts. One is your radiations in the temporal lobe and the radiations in the parietal lobe. So temporal lobe and the parietal lobe, we have got two things which are going. Now what will happen if it is the part of the optic radiations which are in the temporal lobe? That means it will affect the inferior fibers, and because it is affecting the inferior fibers, therefore what I am going to get? I will get the superior quadrant anopia. Superior quadrant anopia, and superior quadrant anopia is called as the pie in the sky appearance. Very important. This will be called as the pie in the sky appearance. So look at this. I have got both sides, the upper part here and the upper part here. So this is your pie in the sky appearance. On the other hand, if I have a problem in the parietal lobe, then the superior fibers are affected. Now because it is the superior fibers, therefore it is the inferior quadrant anopia. Inferior quadrant anopia, this will be called as the pie in the floor. So this is called as the pie in the floor. So this pie in the floor appearance, can you see on both the sides the lower area is affected. This is your parietal lobe. Alright, now look at the optic radiations. Optic radiations are your number 9. So in the 9, what happens is the fibers are going on as they were going from the optic tract. So obviously now what is happening? If all the radiations are affected, because you know when they were passing through the temporal lobe, only one set of fibers were affected. When they were passing through the parietal lobe, only other set of the fibers were affected. But if all the optic radiations are affected, that will be similar, and again I will get what I was getting, contralateral homonymous hemianopia, and that is why I also told you that I will be getting this as a most common visual field defect. Alright, now we next come to the visual cortex. In the visual cortex, we have got two conditions, one sparing the macula and one where only the macula is involved. Sparing the macula, why? Because of the Reason is the double blood supply, because macula has the double blood supply. So if only the posterior cerebral artery is affected, what I am going to get? I am going to get the vision in the central area, because this area is actually supplied by the middle cerebral artery. So I am going to write that this is actually supplied by the middle cerebral artery, and that is why this area is spared. This is called as the macular sparing. While so here I can say that there is a PCA lesion, right? And MCA is supplying it. But in the next case, can you see here? Here I have a lesion in the area which is supplied by the middle cerebral artery. So this is a middle cerebral artery lesion, and I am going to get involvement only of the macula. Now in this series, I would like to show you one more important thing that you can get in cases of the partial lesions of the lateral geniculate body. When we have the partial lesions of the lateral geniculate body, then what do we get actually? In that case, we get the keyhole shaped defect or the tongue hole shaped defect. So that also becomes an important question, so you should know it. So it is something like this. So we are going to get something like this sort of thing. This is called as the keyhole or tongue shape defect, right? Very, very important. And this we get in the partial lesions of the lateral geniculate body. Partial lesions of the lateral geniculate body. Another important thing is that by the time we are reaching actually the visual cortex, by the time we reach to the visual cortex, we start getting the congruous visual field defects. So it was actually incongruous at the level of the optic tract, and then it starts becoming more and more congruous, and by the time we reach the visual cortex, it becomes congruous. So we have the contralateral, ipsilateral, pie in the sky, pie in the flow. We have got keyhole shaped defect, congruous and incongruous. And another important thing is what is heteronymous and what is homonymous. So if you see here, in cases of the bitemporal hemianopia or the binasal hemianopia. In cases of these bilateral as well as binasal hemianopia, these were the heteronymous. These were the heteronymous hemianopias because the opposite sides of both the eyes are affected. But as you reach to the optic tract, we start getting the homonymous hemianopias. And because after the level of the optic tract, it is homonymous till the visual cortex, that is why this is the most common visual field defect. And third thing is that it is contralateral, because if it's a right-sided lesion, I'll get left-sided homonymous hemianopia and vice versa. So that is very, very important. Now I'll tell you about the proximal part of the optic nerve lesion. Now what happens in this case, this is asked as a separate question also, and actually it is not the proximal part of the optic nerve. If you can see here, we are marking here it in this way. So it is not the proximal part, you will say, but it is actually proximal to the optic chiasma. So let me explain you what I am trying to say. This is actually what you called as the junctional scotoma of the trachea. This is the junctional scotoma of the trachea, where we have got the lesion at the junction, of the optic nerve and the optic chiasma. Here we have a lesion at the junction of the optic nerve and optic chiasma. So I can say it is proximal to the optic chiasma. This is proximal to the optic chiasma. That is why we say that the lesion is in the proximal optic nerve, while actually it is in the distal optic nerve. Now what is the logic? It is due to the anterior knee of von Willebrand. It is due to the involvement of the anterior knee of von Willebrand. Now, this most of you know, but actual reason most of you don't know that what is this anterior knee of von Willebrand and what is this happening. I will tell you one very important thing. What happens, see, right side mein we have got right side optic nerve. Okay, so what is happening, suppose I say these are the nasal fibers and these are the temporal fibers. Similarly, these temporal fibers and nasal fibers. Okay, now nasal fibers of the left side will decussate into the nasal fibers of in the optic tract of the right side. So this is your left side temporal fibers and left side nasal fibers. This is your right optic tract. Okay, so what is happening now, suppose there is a lesion here. So what is happening, these nasal fibers have to decussate in this right side optic tract. So they will loop around this optic nerve and then they will decussate. Can you see here? The nasal fibers which have to go into the optic tract, they are making a loop around the right optic nerve and then they are going. So, and suppose this optic nerve was a different colored, maybe suppose you will see that these are the optic nerve fibers, okay, which have decussated here. And already what fibers we were having the temporal fibers of this side and also we were having the nasal fibers of this side, both are coming. So this means that if I have a defect in this area, if I have a defect in this area, what are the things that are going to be affected? It is the right ke optic nerve fibers, both temporal as well as nasal fibers are affected, and also it will affect the left ke these inferonasal fibers. Left ke only inferonasal fibers, because only the inferonasal fibers will be decussating. ये वाले nasal fibers तो अभी same side पे हैं before this. So what are the things which are affected? Right side के temporal भी affect हो गए, nasal भी affect हो गए, इसीलिए right side पे you are getting the total vision loss. Right side पे we are going to get the total vision loss. And what I am going to get in the left, because left ka what is affected? Only the inferonasal, because only inferonasal fibers are affected. Therefore left में I am getting just the supratemporal quadrant anopia. So I hope now this is very clear, and this looping around this is called as the anterior knee of von Willebrand. So इस knee में क्या क्या है? It contains all the optic nerve fibers of the same side but only the inferonasal fibers of the opposite side, and that is the reason that it will cause the total blindness on its side and just the supratemporal quadrant anopia on the other side. So now let's look over the pupillary reflexes, a very important topic, right? So you should know what is actually the pathway of the pupillary reflexes. So if you try to see how do the pupillary reflex work when we show the light. So first I'll talk about the light reflex, okay. So this light reflex pathway starts with the light. So this is very obvious, not a problem, okay. It is starting with the light, and where this light is going, light will be going on this retina. So the next part will be the retina here. This is going to the retina, okay. From the retina, this will be taken up by the optic nerve. So this is your optic nerve which is carrying the impulses, and from the optic nerve, now the impulses are traveling in the optic tract. So your next part will be the optic tract. Alright, now here we have not mentioned the optic chiasma because don't get confused between the visual fibers as well as the pupillary reflex pathway. It was the visual fibers which are decussating, but the pathway of the pupillary reflexes will go this way only. From the light it will go to the retina, from the retina it will be taken up by the optic nerve से optic tract. Now optic tract के बाद it should have gone to the lateral geniculate body. Now this is a very important thing. See, it is following into this lateral geniculate body, but the pupillary reflex pathway will not follow this, and it is coming anteriorly. So it is coming anteriorly, something like this. Can you see this? What is this? This is actually the pretectal nucleus. So basically this is very, very important. The pupillary reflex pathways are going to the pretectal nucleus, and from this pretectal nucleus, can you see, it is going to this EW nucleus. It is going to this EW nucleus, and not only EW nucleus of one side. Now can you see this? It is going to the EW nucleus of both the sides, and this actually actually forms the basis of the indirect light reflex, a very, very important thing. This is the basis of the indirect light reflex. Now from here the story will change, because now we have started with the bilateral innervation. So can you see here? So from this EW nucleus, it is going to the third nerve of this side, the third nerve, and from this EW nucleus, it is going to the third nerve of this side. And this third nerve will innervate the ciliary ganglion. So can you see, this is your ciliary ganglion. So from this it is going to innervate this ciliary ganglion, and then this ciliary ganglion, and finally the ganglion will go and innervate the muscles. The ganglion will go and innervate the muscles. Okay, so basically that is why I am getting the direct light reflex also, and I am getting the indirect light reflex. Direct light reflex on the same eye or the same side, while on the other side we are going to get the indirect light reflex, which is also called as the consensual light reflex. So this was your light reflex pathway. On the other hand, if you see about the pathway of the accommodation reflex, if you see the pathway of the accommodation reflex, then it is same as the light reflex, except the lateral geniculate body instead of the pretectal nucleus, and rest becomes the same. Alright, now we will try to see some important aspects of the optic neuritis. Optic neuritis, see, the most common cause of the optic neuritis is the multiple sclerosis. It is the multiple sclerosis, and you have got three kind of optic neuritis. If you see, one is your retrobulbar neuritis, second is the papillitis, and third is the neuroretinitis. Retrobulbar obviously means that the part of the eye behind the eyeball. Papilla means the optic nerve head. So here the optic nerve head is affected, and third is the neuroretinitis. Neuro plus retinitis. Neuro is the optic nerve, so you have the papilla, and plus retina, which part? Macula. So it is the involvement of the macula along with the optic nerve head. Now, which is common and which is less common? So, if you see, the retrobulbar neuritis is actually most frequently found in adults, and it is the one which is frequently associated with the multiple sclerosis. This information will again help you solve the MCQ. If you are getting a question regarding the optic neuritis and you are having an adult, that means you have to think about retrobulbar neuritis first. This is the one which is mostly associated with the multiple sclerosis. So, if you are having an evidence of the multiple sclerosis, demyelinating disorder, again things of the retrobulbar neuritis first. While the papillitis, here this is most common in children. So if I am giving you the same symptoms and I am saying it is a 5-year-old child, then obviously you will think about the papillitis. And third least common is your neuroretinitis. It is rarely a manifestation of demyelination, right? So this means that if you are getting a question on the multiple sclerosis, or you are getting a question on optic neuritis, only when you get a typical evidence of a macular star, only then you have to think about the neuroretinitis. This should be very, very clear. Now, what are the findings here? So, in cases of the optic nerve head, can you see, we have got the normal fundus, and that is why it is said that neither the patient sees anything nor the ophthalmologist, because in these cases the fundus is absolutely normal and the part of the optic nerve which is outside the eyeball, that is affected. In cases of the papillitis, we are getting the optic disc edema. We are getting the optic disc edema, then we are also getting the blurred margins. We are also getting the blurred margins, and we also get the hyperemia. That means we are getting the congestion, we are getting edema, we are getting blurring of margins. While in cases of the neuroretinitis, the typical macular star formation. The typical macular star formation is the one that we are getting in cases of the neuroretinitis. Alright. Now, can you see? This is the picture, fundus picture showing you the papillitis, and where as you can see that this is a late fundus stage of papillitis where you are getting a lot of exudates which are also present. So, you can see the exudation, okay, lot of exudation is there, no margins are visible, and we have got the congestion present. So, that means this is your papillitis. Then we have got this is again typically showing you the macular star. So, I can say therefore this is a case of the neuroretinitis. While if I get the same set of findings and I am getting the normal fundus. So, if I am getting the normal fundus along with the clinical features of the optic neuritis, along with the typical features of the optic neuritis, that means I have to think about the retrobulbar neuritis. So, this is the way of approaching the questions of the optic neuritis. Now, I will talk something about the typical optic neuritis. So, can you see here we are getting a typical defect on the inferior sides here also. This is also your inferior side, this is also your inferior side. So, this defect is called as the inferior altitudinal hemianopia. Inferior altitudinal hemianopia, which is actually found in the anterior ischemic optic neuropathy. Very, very important. This is the altitudinal hemianopias that we get in cases of the anterior ischemic optic neuropathy. This is your inferior altitudinal hemianopia. Similarly, I can also get the superior one. This is called as the superior. This is called as the superior altitudinal hemianopia. Superior altitudinal hemianopia. Now, one thing which is important, that like we have anterior ischemic optic neuropathy, this can be of two types. One is your arthritic type and another is your non-arthritic type. So, it is only 5% cases that we get arthritic. Mostly we are getting the non-arthritic. 95% is your non-arthritic type. Arthritic is basically found in the giant cell arthritis, and here we get the pale optic disc. While the non-arthritic, which can be found in the diabetes or hypertension, here we are getting the hyperemic optic disc only. Here I am getting the hyperemic optic disc. So, you have to remember this. This is important. Alright. Okay. One more thing. We have got two important conditions. One is your Leber's hereditary optic neuropathy and one is your toxic optic neuropathy. So, these are the two optic neuritis which are behaving somewhat differently. So, you have to look there. Usually, you know, optic neuritis is a unilateral condition while this is a bilateral condition. So, we are getting bilateral diminution of vision here and also we get bilateral central scotomas or the visual field defects, whatever. While in the Leber's hereditary optic neuropathy, which is, you know, it's a hereditary condition, you have to remember the MP, the Madhya Pradesh, you have to remember. So, what is this M and what is this P? Let's see this. So, if you see here, in this case, we have got Leber's hereditary optic neuropathy, 3M and 5P we have. M is the mitochondrial inheritance. We have got the mitochondrial inheritance number one. Number two, it is actually maternally transmitted. Mitochondrial inheritance, it is maternally transmitted. And third M is manifested. This is manifested most commonly in males. So there are 3 M which are important here. Now we'll try to see for the P. What are the things which are important in P? P for painless. This is a painless condition. Like in many cases of retrobulbar neuritis, we can get a deep orbital pain because this optic nerve sheath is getting the adhesion with the medial rectus and superior rectus, so deep kind of boring pain which is even aggravated by the ocular movements, that can be there. But this is a purely painless condition. We get P for primary optic atrophy. Primary optic atrophy is present here. Then we get the pseudo papillitis. It is an important condition where we are getting the pseudo papillitis or the pseudo papilloedema. Then P for pupillary reactions. The pupillary reactions are normal here. They are not abnormal. They are normal here. And we get the peripapillary microangiopathic telangiectasias. So all these are important. I will say, remember it as, you have to remember it as M3P5, and you will be able to learn all the important features of the Leber's hereditary optic neuritis. Then see this. Here also you can see such a large optic disc, right? We are able to see such a large optic disc. So what is this? This is actually a case of the papilloedema. Papilloedema, which is actually bilateral passive optic disc edema secondary to the raised intracranial pressure. So this is a passive condition, and the amount of the optic disc edema is much more. That is why it is an important cause for the enlargement of the blind spot. Another important thing is that we are going to get enlargement of the blind spot here. This is important question that was asked in AIIMS November 2019, that it is one of the cause for the enlargement of the blind spot, and it's a bilateral condition, it's a passive condition secondary to the raised intracranial pressure. Now a very important grading that we usually follow in the cases of papilloedema is the Frisson staging. Okay, so can you see this is your normal, the first is your normal, is this visible? Yes. Then in the second one, we are just getting a gray C-shaped halo. This is called as the C-shaped halo, right? Then it becomes circumferential. So this is called as circumferential halo, it is becoming overall. Then we have got the obliteration. I'll write here now 3, 4 and 5. So in the 3 we are getting the obliteration of the vessel. Obliteration of the vessel near the optic disc. Then we have obliteration of the vessel, at least one vessel on the optic disc, and then all vessels, obliteration of all vessels on the optic disc. So first is a C-shaped halo, then is the circumferential halo, because there is obliteration of the cup, large amount of edema is taking place, and then starts the obscuration of the blood vessels near the optic disc margin. When they are leaving the optic disc, then obliteration of the blood vessel, at least one blood vessel on the optic disc, and all the blood vessels then on the optic disc. Now these are the Patton's lines which we get in cases of the papilloedema. These are the retinal or the choroidal folds that we get in cases of papilloedema. right? So there are so many things by which we can differentiate the papilledema and the optic disc. You will not get any UTOF symptoms, no color vision defects. You will get in papilledema. Papilledema is a bilateral condition. Then you will get the clinical features of the raised ICT, projectile vomiting, the headache. Then a very important thing that you are going to get here is the enlargement of the blind spot. Enlargement of the blind spot. Plus you will also get the clinical features of the raised ICT, like for example is the amyrosis fugax. I will get also the features of the raised ICT here, which I am not going to get in cases of optic neuritis, and therefore the treatment is also according to that. In the papilledema you have to treat only the cause, but in optic neuritis we will give the methylprednisolone. Now coming to the optic atrophy. Optic atrophy. In the optic atrophy, we mainly have three kind of optic atrophy. If I talk about the primary optic atrophy, so always remember that primary optic atrophy is the chalky white in color. It is chalky white in color. And second thing you have to remember that here there is no antecedent optic disc edema. So if I am not getting any history of previous optic disc edema, that means it's a primary optic atrophy. Now if you have to remember the causes, remember the LT3, like classes होती है in the LT, so LT3 हमें याद रखना है. L is your Leber's hereditary optic neuropathy. T for toxic, then we have got T for trauma, and then also T for tumors. So all these are responsible for the primary optic atrophy. Now very important is your toxic optic neuropathy. What are the toxins that can cause? We have methyl alcohol, then we have ethyl alcohol, chloroquine, then we have the chloroquine, then we have digoxin, very important, digoxin. Then we have the ethambutol, isoniazid, also is your isoniazid, right? Then we have got tobacco. Tobacco is causing due to the presence of the cyanide. Then another important drug is your amiodarone. This is gaining importance nowadays, amiodarone. And nowadays chloroquine is, evergreen important. So this is also important, but you have to learn all the drugs. That's why I am specially writing. You have to remember. Then these two drugs from the ATT, you have to remember that sort, that ATT can also cause optic neuritis, right? And then it can also be the deficiency of vitamin B1, B2. Then we have got B12 deficiencies. All this can be there. So how can we actually treat this? For the treatment, you have to give the injections, intramuscular injection of the vitamin B12. You have to give 1000 microgram. This is given weekly and for 10 weeks we have to give. So this is the ideal treatment of the toxic optic neuropathy. Then we have got the secondary optic neuropathy. The secondary optic neuritis, this is actually secondary, means it has secondary to the previous optic disc edema, and because optic disc edema has already taken place, therefore this will be dirty white in color. And what are the causes? For the causes, you have to remember the pap smear. P for papillitis, then we have got A for anterior ischemic optic neuropathy, and then again P is your papilledema. So in this way you have to remember the causes of secondary optic neuropathy. Okay, so can you see here the color? Can you concentrate here? Just the chalky white in color. So I will say this is your primary optic atrophy. While if you see this one, this is your secondary optic atrophy, dirty white in color. And then finally we come to the third one. the tertiary optic atrophy. Tertiary means it is due to the retinal diseases, secondary to the retinal diseases. So you have to remember here the pale yellow waxy optic disc. And what can be the causes here? The causes here is your C reactive protein. C reactive protein, C for CRAO, C for CRVO, and the retinitis pigmentosa. This is your tertiary optic atrophy. And can you see, this is a typical case of the retinitis pigmentosa. We are getting the thin blood vessels, we are getting the retinal pigmentation, pale yellow waxy optic disc. So in the retinitis pigmentosa also we are getting the tertiary optic atrophy. Now quickly see the anomalies. These are the optic disc anomalies. You can see the inferior crescent. So this inferior crescent is actually seen in cases of the optic disc coloboma. Can you see this crescent is visible? This is your optic disc coloboma. Then see, these are your optic disc drusen's. They are autofluorescent optic disc drusen's. Then we can see the myelinated optic disc, and this will also present with the important thing, that is your enlargement of the blind spot. This will also lead to the enlargement of the blind spot. And then we get this. What is this? Can you see this? We have got two arrows here. This is actually the double ring sign that you get in optic disc hypoplasia. In cases of the hypoplasia, you are getting the small size optic disc, and we get another ring that is corresponding to the normal size of the optic disc. So no enlargement of the blind spot you are getting. This was a question that was asked, that enlargement of the blind spot occurs in all except. So answer was hypoplasia, because here we are getting the small size optic disc. So obviously there is no point of getting the enlargement of the blind spot here. And then the last one is your morning glory syndrome. Morning glory syndrome mein what you are getting, this is your scleral defect, where we have the absence of the lamina cribrosa. Absence of the lamina cribrosa. Thank you.